Okay, thank you. Good morning, ladies and gentlemen. I'm going to speak to you about artificial blood substitutes in this lecture. My name is Aamer Ahmed. I'm an associate professor in the Department of Cardiovascular Sciences in Leicester, the UK, and I'm also a cardiothoracic anesthesiologist in the Department of Critical Care and Anaesthesia at Glenfield Hospital. And my remit in this lecture is to give you an idea about artificial blood substitutes. So here we go. First of all, just as an introduction, artificial blood is probably the single most desired holy grail in medicine that we've always needed. It's something that is still just out of our reach, and it's something that we still pursue. And whoever gets to it will either be very, very successful and probably get the Nobel Prize for advancements in patient care. So artificial blood is really important because blood substitutes have the potential to transform medicine completely. It's important to remember that a blood substitute is not the same as an artificial oxygen carrier. So an artificial oxygen carrier will not perform the other duties of functions of blood. It will only carry oxygen. So what are the other functions of blood? Well, apart from oxygen delivery is a very main one. But after that, there's the creation of vascular volume. So our pipes, our arteries and our veins are supported by volume, and that is one of the functions of blood. Blood also deals with coagulation and immunity. So it carries white cells and antibodies, as well as the factors, as we've talked about in previous lectures, the platelets and the clotting factors from the liver. And those things cause coagulation to take place whenever we damage our blood vessel or damage our skin. It's also involved in transport of energy and wastes from the gut and the organ systems, and also involved in the transport of neurohumoral mediators such as hormones from your thyroid, from the pituitary gland, from the endocrine glands as well. But today what we're talking about is really oxygen delivery, which is the important aspect of oxygen carriage. So why is there a need for this? Well, as you know, blood is a rare resource, it's an expensive resource, and there are increasing costs for collection and processing and storage of blood. And there's a lot of concern within the public about infection agent transmission as well. As you know, in the 1980s, there was HIV and hepatitis B, and there were some scandals that took place over that. More recently, there's cytomegalovirus and bovine spongiform encephalopathy. And I guess in the near future, people will start worrying about COVID-19 as well. But infectious agents can be transmitted through blood. And that's something that all patients are really worried about if you talk to them. There's a shortage of donors. So blood is a finite resource. It comes from other patients and other people. So we rely entirely on other people donating red cells and plasma products to us. And if there's a shortage, or if there's a situation like a war or an explosion or a major catastrophe, then we run out of blood and the blood banks run out and we need more donors. And then finally, there's the real, rare but real problem of incompatible blood group transfusions. So just like giving a patient the wrong drug, blood is, in fact, like another pharmacologic agent. So if you give the wrong blood group to the wrong patient, you will cause a catastrophic graft versus host reaction, and sometimes an anaphylactic reaction, and sometimes even death. So it's something that we need to think very, very carefully about. So what we would want to do is to try and eliminate all of these problems by using an artificial blood. So there are three major problems in donor red cells. First of all, we need to cross-match red cells at the moment, and that's due to the fact that there are different groups. They have a relatively short storage life. We can only store blood for, at best, about a month and a half. 42 days is what we do in the UK, but blood starts to deteriorate quite quickly. And as I said earlier in the lecture, transmission of infectious agents and anaphylactic agents is always a worry as well. And also, if you look at the arena in which I practice, for instance, in cardiac surgery, immunological effects of blood transfusions are associated with more higher rates of surgical infections, delayed wound healing, progression of cancer, and in cardiac surgery, even 1 to 2 units of red cell transfusions has a difference in 1 year and 5-year mortalities, everything else being the same. So blood transfusions are not without risk, and the immunological effects of blood transfusions are poorly understood. But the reality is that if you give patients blood, they are less likely to heal well. It takes longer to heal, and their cancer progresses. What would be ideal properties of a blood substitute? We would want something that could take up oxygen and deliver physiological oxygen tensions similar to what a natural hemoglobin does, and carbon dioxide transport as well. The ideal blood substitute wouldn't have any major toxic side effects, no chemical reactions with oxygen carrying it rather than reacting with it, and no reactions with the complement system or the white cells within the blood. It would be easily metabolized and eliminated by the body. It should not interfere with circulation. It should have a sufficiently long intravascular half-life so you could give it and it stays within the vascular space for long enough. And they should be easy to store and use, eaten stable, with long half-lives and low costs. And they should be able to maintain both arterial pressure and acid base, and also plasma viscosity. So this is the ideal. Question is, will we ever get there? So there are two sort of major approaches to this problem of artificial blood, if you like. There are two types of things we could do. There are artificial oxygen carriers, and within those artificial oxygen carriers, there are hemoglobin-based oxygen carrying solutions, or there are perfluorocarbons in the form of emulsions. And these two sorts of solutions are completely different in the way they work and what they do, and we'll talk a little bit about them shortly. So hemoglobin-based oxygen carriers, the HBOCs, they're made from modified hemoglobin. They can be either human or bovine derived. They're either using free hemoglobin or by cross-linking hemoglobin, different subsets of alpha or beta, or they can be used on the basis of polymerization of glutaraldehyde, so you get multiple molecules of hemoglobin stuck together, or they can be encapsulated in little micelles or vesicles, and there's further things that we're looking at using genetic engineering and bacteria and yeasts to carry hemoglobin-based oxygen. But the reality is, we'll talk a little bit about the structures of how these work, but they're all hemoglobin-based. So they take the nature's model of hemoglobin and they try and mimic that in order to create artificial blood. The advantage of these solutions is that they don't activate white cells, they increase EPO production within the patient, and they generate, and they've been shown to have satisfactory oxygen delivery even when the patient's hemoglobin is down as low as 2 grams per deciliter, with no side effects. So they have a greater reperfusion than blood. They cause significantly better systolic and diastolic LV function if you have coronary artery occlusion, and they totally obviously alleviate viral transmission. So the advantage of these solutions is that they can support the circulation, they can deliver oxygen at low hemoglobin concentrations, and that they don't have very many adverse side effects like viruses or white cell activation. And there are a few different types over the years. In the last 20 years or so, there have been many different types. Some have been based on human-based source of hemoglobin, some have been based on bovine. And just to give you an idea, the fifth column here, which I've referred to here, this is what human blood's values are. So human blood has a concentration of about 13 grams per deciliter. There's a P50 around 26. It's a certain viscosity and exerts a low colloid oncotic pressure. But some of the other new ones that we've had polyheme, which is human-derived. We've had HBOC 200, which is bovine-derived. The main differences here, as you can see, the P50s are quite high here, and on the same one here as well. But some of the other ones, the P50s are very, very low. So these have shifted the oxygen hemoglobin dissociation curve to the left, and you'll see this later on in my lecture. The colloid oncotic pressures are much higher in some of these as well, so they stay intravascularly for much longer, and that's an advantage to what we're looking at as well. So what are the uses of hemoglobin-based oxygen carriers? Well, you imagine any aspect in medicine where we need to give volume resuscitation urgently, or we need to give blood urgently, and those would be the situations where we would choose to use hemoglobin-based oxygen carriers. So shock is the first one. There's hypovolemic, cardiogenic, or septic shock. All of these would be sources where we would use HBOCs to improve oxygen delivery to the organs. Any form of organ ischemia or red cell incompatibility, where we don't have sufficient red cells of the right group, we could use that. In acute lung injury and organ preservation, where we want to perfuse organs that have been taken for transplant, that would be very, very useful. Cardioplegia solution, again, it would be very useful in sickle cell anemia and in air embolism, where if you get oxygen delivery that is being impaired, then you could use some of these solutions for that. So clinical uses, actual use of what we would do in theatre. Elective surgery, well, certain types of surgery we still do preoperative acute normovolemic hemodilution. And at the moment, what we do is we take out the volume of blood that we want to take off the patient, and then we replace it with crystalloid or colloid. So instead of doing that, we replace it with the hemoglobin oxygen carrying solution, and it should improve oxygen carriage capacity without affecting the actual amount of red cells that are present. It can be used for perioperative volume replacement. So all those places who will use colloid regeneration at the moment, we could think about using HBOCs for those. And within my arena of cardiovascular surgery, we can use it for pump prime, which at the moment is a mixture of mannitol and crystalloid solution and colloid solution. It could be used to prime the circuit with oxygen-bearing solutions rather than solutions that are purely salt-based, and in volume replacement as well. Within trauma, particularly within the military arena, that would be very useful in the battlefield. So in major trauma where patients come into the emergency room where you require urgent stabilization, urgent volume replacement, what the organ systems need is oxygen delivery to the end organs. And that's why they become acidotic, and that's why they become hypovolemic, because the circulating volume has gone down and the end organs are not receiving sufficient oxygen. And that takes us to the next stage, perfusion of ischemic tissue. So where there is thrombolysis taking place in coronary artery occlusion, for instance, you want to deliver a high concentration of oxygen to those areas that are ischemic. That would be useful. In sickle cell disease, when sickling is taking place. In stroke, again, where beyond the stroke is embolized thrombose to the area of the brain tissue is being affected by hypoxia, and in peripheral vascular disease and hemolytic anemias. Within the cancer therapy arena, radiotherapy and chemotherapy, oxygenation of solid tumors is another use, and organ preservation. If you want to preserve a heart or a lung or a liver for transplantation, by the time it's taken from the donor and transported across the country and brought to your transplant unit to implant into the patient, it can be as many as 4 or 5 hours. And during that time, the organ is being ischemic and is being held cold. But if we could perfuse those organs using hemoglobin-based systems, that would be very useful. And similarly with cardioplegia solution for arresting Aamer in cardiac surgery. So there are problems like everything else. These are still new agents. Although they've been around for a long time, they're still not perfect. And the main issue with hemoglobin-based oxygen carriers is that they release inflammatory cytokines, and that then causes arterial pressures to go up within the patient. So some people worry about where is the hemoglobin coming from? Is it bovine? Is it genetically engineered? Are we using old, outdated bank blood or recombinant DNA technology? There's some public issues about that. And also the nitric oxide scavenging effects in combination with the inflammatory cytokines lead to intolerable side effects, which you will see later on. And these are sort of the adverse side effects that you get. So you can get immunosuppression, you get nephrotoxicity, you get vasoconstriction leading to an increase in mean arterial pressure because of nitric oxide inactivation and endothelins. They interfere with lab results. You can get some neurotoxicity because of nitric oxide inactivation and free radical formation, and a little bit of cardiomyopathy sometimes as well. So they're not without risk. There have been several different types available. They all tend to be binders of nitric oxide. Hemolink is one that I did a study in about almost 20 years ago, which is raffinose linked using a sugar molecule to polymerize hemoglobin. They all lead to a raised systemic vascular resistance, mean arterial pressure, and pulmonary artery pressure. So all of them cause hypertension, sometimes really severe hypertension, and vasoconstriction as well. Now that may be beneficial in hemorrhagic shock and sepsis patients, where we're using the side effect to actually benefit what we're doing. And the other advantage is that it doesn't interfere with the coagulation system. But they do and can cause anaphylactoid reactions because sometimes they're based on bovine or sheep-based hemoglobin. They can impair white cell function, and sometimes the patients appear different, so they can get jaundice and skin discoloration, hemoglobinuria. The physical properties of these vary depending on which drug you're using and which derivative you're using. So I've got 3 listed here, which is BioPure and the Baxter DCL HB, diaspirin cross-linked hemoglobin, and the one in the middle, Northfield. And the main differences you can see here are that they've got similar oncotic pressures, although the diaspirin cross-linked hemoglobin, the Baxter one, exerts a higher oncotic pressure. The average weight of the molecule changes depending on how many times it's polymerized, and the plasma viscosity changes. But the other important thing is the half-life. So how long does it stay in the circulation? Some of the other agents here, such as BioPure and Northfield, stay in the circulation for much longer than the diaspirin cross-linked hemoglobin as it's eliminated. And these are the side effects that you get, which we just talked about. You can get vasoactivity and hypertension because of nitric oxide effect, but you can get GI upset and pancreatic liver enzyme elevation leading to jaundice. You can get oxidative stress and the cardiac involvement, hemostatic issues, sometimes neurotoxicity and kidney dysfunction as well. So let's move on to the slightly different group of compounds we're talking about. These are the perfluorocarbons. And the main difference between these is these are not hemoglobin based at all. These are liquids that physically dissolve oxygen in direct proportion to the partial pressure of oxygen in contact with the solution. So in other words, the higher the tension of oxygen in contact with these solutions, the more they will dissolve. They don't bind to oxygen, they don't react with oxygen, but the thing is, at the FiO2 of 100%, they bind 40 to 50% oxygen compared to blood, which only dissolves plasma of about 3%. So the ability to carry oxygen is much better, but they do require higher FiO2s in order for them to function properly. They also have a linear pattern of oxygen unloading, unlike the oxygen hemoglobin dissociation curve. So the higher the tension, the more they will load. Similarly, the lower the oxygen tension, the more they will unload. And you'll see that in the shortly. So the result of that is better unloading of oxygen, low oxygen tensions, which is what you want in an ischemic area. And they're eliminated by phagocytosis and excreted as vapor from the lungs. So what are the main differences between perfluorocarbons and these and red cells? They don't chemically bind to the gas, but they physically dissolve O2. So a little bit like what plasma does. So hemoglobin actually binds to oxygen, whereas plasma dissolves it. The oxygen unloading and loading is then therefore twice as fast because it's dissolved in solution. The extraction rate of hemoglobin is lower, but with PFCs is much higher. When in areas of ischemia, you can extract more oxygen per unit volume of PFC. Red cells have a fixed carrying capacity, whereas the PFCs can vary according to the FiO2. So this goes back to what I was saying. You need to deliver a high oxygen tension in order for the perfluorocarbon to carry a high amount of oxygen. And therefore, there's an improved driving gradient. And also, the perfluorocarbons physically are much, much smaller in terms of their spherical size as red cells, so their flow characteristics are better, and they will move more easily through microvasculature and capillaries. But red cells are less deformable in areas of ischemia as well. So what are they made of? Well, the first generation were things like fluosol DA, which has actually been withdrawn now, that was stored frozen, and it had limited oxygen carrying capacity, but had lots of allergic reactions, so it's been withdrawn. And the newer ones are based on halogens rather than hydrogen atoms. And the second generation one is called oxygen. That can be stored at 4 degrees. It has a high oxygen carrying capacity. There are some newer agents that have come along as well, the third generation ones, which you'll see as well. And emulsification techniques have recently allowed a greater concentration of the compound and reduced coalescence. So a little bit like propofol, if you emulsify them using phospholipids, they allow better long-term stability, and some of the side effects are reduced. However, they do still cause side effects. So you get facial flushing, you can get backaches and headaches, you can get nausea and a temperature rise as well. And occasionally, just like with propofol or etomidate, anaphylactoid reactions can take place due to the emulsifying agent that's being used. They can activate the coagulation process, and they require a high FiO2 to bind large amounts of oxygen. So the problem with these agents is you may need to use them only in ventilated patients because it's only there where you can deliver an FiO2 of 1 or thereabouts. In lower FiO2s of 0.35 or 0.4, these agents are not as good in terms of oxygen carrying capacity. So they're only really useful for liquid ventilation. And they also have adverse side effects. As I said to you, they also increase liver enzymes. They can cause right-sided heart failure because of pulmonary hemorrhages and pulmonary edema. They can cause headaches and flu-like symptoms, and they can cause a bleeding tendency because they interfere with platelet counts as well. And the allergy was a real problem with the first generation, which has been withdrawn. The second and third generations are a little bit better in terms of their allergenic response. And the hemoglobin-based oxygen carriers, some of them are based using free hemoglobin rather than using polymerized hemoglobin molecules. And the thing with free hemoglobin is that you don't need cross-matching. The solutions contain red cell debris causing renal failure. There's loss of superoxide dismutase and catalase. The P50 changes from 3.7 to 1.3, so it moves to the left, and they're dissociates into dimers outside red cells. So the old sources of these may be old bank blood or bovine. And similarly, options you can use is you can either polymerize these and make them into dimers, or make them into trimers or polymers. But the fundamentals are that using the hemoglobin molecule to move. So let's have a look at a little bit about the dissociation curve. This is a standard oxygen hemoglobin dissociation curve for oxyhemoglobin. So that's the blue line that you can see. And as you can see, the Bohr effect is when you have the presence of CO2 or acid and it moves the curve to the right. And similarly, moving the curve to the left is in times when there is temperature reduction or reduction in 2,3 TBG or alkalinity. So that's known as moving the curve to the left. And you see that sort of trend in fetal hemoglobin. Along the bottom line, you've got a PO2. Along the top line, you've got oxyhemoglobin saturation. And the P50 is the point where 50% of the oxygen is saturated. So at any given PO2 here, the P50 changes. So you'll see this in the next slide. That this for normal oxyhemoglobin, you'll see the changes in the other substances shortly. So if you look at perfluorocarbons here, this is the oxygen content on the vertical axis and partial pressure oxygen here. Hemoglobin is uses a sigmoid dissociation curve, so it saturates very easily at low oxygen tensions and stays saturated. But then as the partial pressure increases, there isn't much increase in terms of oxygen content of blood because it relies on dilution of an absorption of oxygen within the plasma rather than binding oxygen within the red cells. The PFCs, on the other hand, show a linear response. So as the oxygen tension goes up, the amount of oxygen dissolved within the PFCs goes up in a linear fashion. And this is the same thing that's mimicked within plasma. But as you can see, at any given oxygen tension, the PFCs carry almost 3 to 4 times as much oxygen content as plasma does. But it's completely unlike red cells, which hold hemoglobin, and they demonstrate a sigmoid curve. So this again shows the same thing. The fluorosol DA shows a linear response, and oxygen shows a linear response, but higher oxygen carrying capacity, whereas blood and free red cell solutions, as I said earlier, moves the P50 to the left, and diaspirin cross-linked hemoglobin follow the sigmoid sort of dissociation curve. And this illustrates the same thing. So Hemolink is a sheep-based derived solution, which follows this sort of curve here, following a sort of a sigmoid pattern here. And the interesting thing here you can see is that the P50 is the point at which oxygen is 50% saturated. That shifts to the left in certain agents. So the diaspirin cross-linked hemoglobins, the P50 is much over to the left, which means there's much greater affinity to hang on to oxygen in low oxygen tensions, whereas the P50 in some of these other agents here is much higher over here. So oxygenation, if you think about the oxygen tension, oxygenated blood leaves the lungs here in the red zone. All of the hemoglobins are pretty well saturated in this area. Then as the blood returns and goes through the organ systems and goes through the body, it enters areas of low oxygen tension. And this is where it's important that some of these drugs release the hemoglobin to release the oxygen in areas of low partial pressure. And this is what happens in gas exchange. This diagram just illustrates what's happening here. So oxygen is going in, CO2 is coming out the lungs, and you've got deoxyhemoglobin that's being returned from the red cell, becoming oxygenated, and becoming oxyhemoglobin and going back to the red cell. This is the chemical reaction that takes place. The CO2 is eliminated using carbonic anhydrase, and then the ferrous state of iron becomes ferric by becoming oxygenated. So what are the applications and indications of all these solutions and all of artificial blood, if you like? They can't really be used as volume expanders, but what they do is they reduce the need for donor blood during surgery. They can be used as aids for dilution, and they can allow a greater degree of donation. They can be used in trauma resuscitation by restoring the oxygen carrying capacity. And they can be used for pump priming. Similarly, in septic shock syndromes, the nitric oxide and the cytokine reaction that causes the hypertension to develop can actually be beneficial in septic shock to support blood pressure rather than requiring lots of inotropes. Similarly, perfusion of ischemic organs prior to transplantation is important. Hypoxic tissue beds, perfusion of ischemic ulcers or limbs where clots have taken place, rendering acid-based generation of the leg, and liquid ventilation in patients who are in intensive care unit with an endotracheal tube using higher FiO2s. And this may prove to be a benefit in the situations where we're currently in, such as the COVID-19 situation and so on. And anti-tumor therapy as well for hypoxic cells within the tumor. And this really just talks about what the context is. So restoration of fluid volume leads to reducing blood transfusion, and it means that we don't have to worry about red blood types. We can simply give an off-the-shelf solution to any patient that requires resuscitation of volume. Similarly, areas where we want to reverse local tissue ischemia, such as PTCA or angioplasty in the heart, and enterocolitis, necrotizing enterocolitis, or myocardial cerebral ischemia after strokes, a high concentrated delivery of high oxygen tension using these solutions could be beneficial. And the rest of them are sort of self-explanatory as well. So let's talk a little bit about artificial blood cells now. So we've talked about free hemoglobin solutions. We talked about polymerized hemoglobin solutions. We've talked about non-hemoglobin solutions completely, which are perfluorocarbons. There is more and more work going on to develop artificial red blood cells. And these are fundamentally cells or micelles or liposomes that have been created to encapsulate hemoglobin in a cell-like structure, so almost like an artificial RBC. And the way these work is as such: you create a phospholipid bilayer using cholesterol, and you coat it, and then you implant hemoglobin within that cell-like structure. But the advantage of this is that you don't have any of the antigenicity, you don't have the grouping that you need to do. You create some ultrastructural modifications, so you can go from cross-linking those hemoglobin molecules. So you could conjugate them or cross-link them and create a high concentration of hemoglobin within each micelle, and create a red cell which can carry more oxygen per red cell, and using recombinant DNA techniques as well, and using tetramers as well. And this is what they start to look like. So the very first generation of these nano-architectural assemblies simply polymerized and cross-linked the hemoglobins. Then the next generation came along and they created polymerized hemoglobins more in the structure of a sort of using superoxide dismutase and rubirithlin to create hemoglobin molecules that are more shaped together, but offering a greater density per unit. So here we've only got 2 units, here we've got 3 units, here we've got 6 units, or 7 or 8 units within each cell. And then there's cellular types, things that we've been talking about now, which are basically trying to create an artificial red cell. And what these are taking is they're taking concentrations of hemoglobin, encapsulating it in liposomes or phospholipid bilayers, and then using that to then create a polymerized artificial red cell. And this is how they work. So this is what the cross-linked hemoglobin looks like, the polymerized hemoglobin looks like this, and the conjugated hemoglobin looks like this. And then you take these and then you wrap them in lecithin phospholipid to create this sort of structure here, and then that is then sent around as an artificial red cell. And so there's been work taking place here where you can polymerize them, you can encapsulate them, you can then put them all together into a micelle. You use dialdehyde heparin and hemoglobin inside to finally create this sort of structure here. And this is a polyethylene glycol-based liposome, where you've got lots of hemoglobin molecules inside the phospholipid bilayer and polyethylated glycol to create a hemisphere or a sphere of an artificial red cell. Just to give you an idea of sizes, the initial molecules that we developed, the cross-linked hemoglobins and the polymerized hemoglobins, were all very, very small. They're the size of antibodies and albumin. As they get bigger and bigger, these polymerized groups and the polymeric red cells are the size of 5 or 6, but they're still smaller than the red cells and the white cells and the microparticle-based drugs. And this is not really something that you need to worry about too much, but this just gives you a chemical structure of how the HBOCs have been created. So some have been raffinose bound, such as Hemolink. Some have been bound together using polymolecular structures. Some are using amides, and some have been cross-linked using aspirin. But the fundamental structure is saying that you've got hemoglobin with something binding it together. So hemoglobin, something binding it together. And these are all holding that structure together to give a greater size molecular weight, but more and more oxygen per unit of hemoglobin. And so there have been some clinical trials that have been taking place of these drugs. Just to talk about clinical trials, most of these have been used in different types of arenas. So I'm going to talk about Hemopure, I'm going to talk about Polyheme and Hemocyst. And what they've been used in surgical patients, they've been used in trauma patients, and they've been used in stroke patients as well. And what they do is predominantly these are the clinical trials that have been done. So they give a small amount of dosage of these drugs, and they've looked at physiological effects. So we found that, for instance, using Hemopure, as I said to you, because of the nitric oxide effect, the mean arterial pressures go up, the acid base goes up, and the hematocrit goes down a little bit. The mean pulmonary arterial pressures go up. But the important thing is the oxygen extraction's gone up, the red cell use has gone down, and they were using fewer red cells in these patients. They were reasonably well tolerated. Similarly with this one, with Polyheme, which is human-based, far fewer physiological effects were reported, maintained the total hemoglobin concentration, but not the red cell concentration. And there was some increased cardiac side effects noted in trauma patients here, when the standard would be to give standard resuscitation versus nothing at all. And finally, in this group, again, we see the same sort of things: raised SVR, raised PA, pulmonary artery pressures, and pulmonary vascular resistance, however, leading to a reduction in red cell use, but the side effect is a reduced cardiac output, so they may well need inotropic support. And then the other groups we were talking about, we've seen jaundice, hemoglobinuria, and pancreatitis. So these are not perfect agents by a long way, but we're making progress towards getting to the right agents. This slide and the next one is really just to show you all the physical parameters of where the current hemoglobin oxygen-based carriers are. So I'm not going to go through all of this in detail, but they just show the oncotic pressures, the plasma viscosity, and the P50s of all these values and where they're derived from. So these are the hemoglobin oxygen-based carriers, and these are the current perfluorocarbons. You've got the first generation, second generation, and third generation agents, all of which have different half-lives, different oxygen delivery carrying capacity, and the equivalence of how much hemoglobin there is. So if you think about what the benefits of the physical effects are, higher oxygen solubility coefficient leads to an advantage in resuscitation, in pre-op blood donation, in perioperative hemodilution, and organ preservation. So the more oxygen you can deliver per volume of agent, the better it would be for these organ systems. Low viscosity is an advantage in sickle cell disease, in vascular disease, and in synthetic blood vessels, such as ECMO or cardiopulmonary bypass or hemodialysis circuits, because obviously there's less adherence to the pipes and therefore better flow characteristics. High density means you can use it in alveolar recruitment and liquid ventilation in patients, and the high nitrogen solubility and inactivation nitric oxide means that they have an advantage in septic shock and decompression sickness as well. So where's the future going to take us with these? We're going to potentially look at transgenic hemoglobin prepared from transgenic pigs, which has had much of the immunological mediators taken away. Stem cell technology continues to get better and better, so we could potentially go down the route of producing red cells of specific groups. So instead of going down the free hemoglobin structures or the perfluorocarbons, we could simply produce lots and lots of group A or group B or group AB positive red cells. The development of artificial blood continues. So if you think about blood and all its components, including plasma, white cell counts, white cells, fibrinogen, and all the other things, there's still work going on in creating the ultimate mix of artificial blood to mimic what is happening in the human body. And polyhemoglobins and complexes microencapsulation continues to create the ideal artificial red cell with ideal plasma viscosity dynamics. So what we really need to think about as clinicians is what's really the most effective strategy to resolve these problems that we've got with hemoglobin oxidation. Should we be looking at re-engineering the hemoglobin molecule or exploring alternative keeper mechanisms such as endogenous scavenger proteins in complexes or free form? So we're titrating or dealing with the side effects rather than re-engineering the hemoglobin itself. And then the other question is, when blood isn't available, either because somebody doesn't want to have it or because it's incompatible because of religious objections or incompatibility, should the ratio relative risk to benefit be reconsidered? Because at the moment, we don't reach for hemoglobin-based oxygen carriers because they're considered to be quite dangerous. And should we be re-looking at the risk of this and saying, well, perhaps we should be using them a little bit earlier? And would nanoparticles or stem cell-derived red cells be a more viable solution in the future rather than making blood substitutes, what we're trying to do at the moment? So a few things to think about for the future, but I hope that gives you a whistle-stop tour of where we are with artificial blood and manufacturing. So take-home message here is really there are 2 or 3 different types of ways of doing things. You can create artificial red cells that have got hemoglobin molecules inside. You can create perfluorocarbons, which are emulsions that concoction, and you can create polymerized hemoglobin solutions as well, or hemoglobin-based oxygen. All of which have side effects, all of which have advantages. Thank you very much indeed.